So hello, student doctors. It's my distinct pleasure to be lecturing to you in this new format, voiced over PowerPoints in the brave new world that includes coronavirus. A word of wisdom, stay strong and we'll get through this together and we'll emerge on the other side, changed people, but we'll stay strong. So these first 9 slides are bonus slides, and they are specifically foundational material that's going to help you understand the clinical relevance of the following lecture. So while these first 9 slides are not on the test, they are extremely important for your ability to understand the material that I'm about to present in the GIGU lecture, Genetics of GI Disorders. I'm just laying the foundation not only for this lecture, but for year 2 and your understanding of ADME, absorption, distribution, metabolism, and excretion, and drug metabolism and drug transport. So I'd like to start out the lecture by talking about a clinically relevant drug-drug interaction. More specifically, this case is a herb-drug interaction, but let's not kid ourselves. Herbs are actually drugs, aren't they? Think of willow bark and aspirin. So the topic here is so-called miracle babies. The question being asked is, how did I get pregnant while I was on hormonal contraceptives or the pill? One likely answer has to do with one may have been co-administering herbal remedies, or in fact drugs. One popular herbal remedy is called St. John's wort. It's available over the counter at GNC and the mall on Range Line. Folks commonly self-medicate with this for depression, and it seems to work quite well. There are biologically active substituents in this herb, which are drugs. 2 are called hyperforin and hypericin. These are discrete compounds well known to induce CYP3A4, and CYP3A4 is a very important drug metabolizing enzyme. So in effect, induction of the CYP3A4 enzyme by hyperforin and hypericin chews up or lowers the level of birth control hormone in serum, because birth control is a CYP3A4 substrate, and CYP3A4 is being induced by hyperforin and hypericin when you take St. John's wort. The net effect is decrease birth control effectiveness, and that is oftentimes the answer. If it's not St. John's wort, it may be another herb or another drug that also induces CYP3A4. It turns out CYP3A4 metabolizes approximately 50% of all clinically prescribed drugs. Moreover, it's one of the most highly inducible genes in our body. All right then, let's go back up to 10,000 feet and talk about drug metabolism and Cytochrome P450s. Sometimes you'll hear people say Cytochromes P450 because there's 54 of these guys expressed in our bodies in different tissues. But we're going to focus mainly on the GI-GU aspect. Okay, you're a physician and you prescribe a drug for your patient. The pharmacist dispenses it and the patient eats it, and it gets into their intestine and it's metabolized at some level there, but the very next stop is the liver, where fully 10% of the total liver protein is Cytochromes P450 and mostly CYP3A4. So that enzyme does oxidative metabolism. It's also called phase 1 metabolism, and it results in the introduction of an OH group somewhere on that drug. And what's interesting about that is that OH group becomes a reactive site for so-called phase 2 or conjugated metabolism, where things like glucose can get stuck, sulfonation, or even glutathione, a tripeptide, and various other amino acids can get stuck to that OH group, which becomes, again, a reactive site for things like glucose, sulfonation, and glutathione. Okay, so we've covered phase 1 oxidative metabolism, phase 2 conjugated metabolism, and then there's so-called phase 3 metabolism, which isn't metabolism at all. It's really drug transport and drug efflux. So this would be uptake, and this would be getting drugs out of the cell. And that's how drugs get out of the body, through urine, feces, sweat, breath, saliva, bile. Ultimately ends up in feces, doesn't it? So again, the drug is excreted using this molecular mechanism. This whole thing is called biotransformation. The whole thing is called biotransformation. And we biotransform drugs to get them out of our body. And the net effect of biotransformation is to take a lipid soluble or a fat soluble drug and convert it into a water soluble drug. That is the function of biotransformation. What's interesting about that is not only are drugs metabolized this way, so are a lot of endobiotics, which could be things like steroids, bile acids. The very same pathways that move drugs through our body are the same pathways that steroids and bile acids are eliminated from our bodies through biotransformation pathways. So let's dive a little bit deeper into Cytochromes P450. They rank first in catalytic versatility and the number of foreign compounds that they act upon. So xenobiotics literally translated means xeno means foreign, biotic are compounds. So xenobiotics, foreign compounds. Drugs. So not only do they do monooxygenation, aka oxidative metabolism, in other words sticking an OH group on there, they do a multitude of other reactions. The net effect is to detoxify or even activate a prodrug into a drug. We talked about that with carboxyl esterase. So it turns out Cytochromes P450 can metabolize prodrugs into drugs too. That's a medicinal chemistry trick. What are they? Well, they're heme-containing proteins enriched in liver microsomes. What is a microsome? It's nothing more than a biochemical fraction in a test tube, and it turns out it's smooth endoplasmic reticulum in the liver. That's where Cytochromes P450 live. These enzymes determine the intensity and duration of drug action. They're also involved in the biosynthesis and breakdown of certain steroid hormones, endogenous steroid hormones, as well as hormones that we'll use in pharmacotherapy and in medicine. They catalyze the oxidative metabolism of bile acids, fatty acids, and eicosanoids. So they not only biotransform drugs, they also biotransform endobiotics. In other words, compounds that are endogenous to our own biochemistry. So now I'd like to give you some specific examples of the types of reactions that Cytochromes P450 can do, and that they're extremely versatile enzymes. We already talked about oxidative metabolism. So more than that, they can do epoxidation, oxygenation, N-hydroxylation, dealkylation, oxidative group transfer, cleavage of esters, and dehydrogenation. So you can see from this list that Cytochromes P450 are catalytically versatile enzymes. Okay, from a pictorial version, NADPH is generated from where? Pentose phosphate. 2 electrons are abstracted from NADPH to produce 2 NADP+. Those electrons are passed to FAD, to FMN, and cytochrome P450 lives in the endoplasmic reticulum. If you see this lipid bilayer, this is smooth ER, and that's where these enzymes live. And what's interesting is cytochrome P450 always occurs in association with cytochrome P450 reductase, and the reductase provides the electrons from pentose phosphate pathway, passes those electrons to heme, which uses molecular oxygen. At the end of the day, a water is produced, and a lipophilic substrate, a drug, is converted to a more polar metabolite that has an OH group. So that's kind of the nuts and bolts of this. So in our little vignette in the beginning regarding birth control, that is induction of this P450 enzyme activity by St. John's wort increases the metabolism of birth control, and this allows your body to chew it up and excrete it. Now that I have described to you the mechanism of drug-drug, food-drug, and herb-drug interaction using St. John's wort, hyperforin, hypericin compounds in that herbal remedy as an example, I'd now like to describe to you the molecular mechanism of how that induction of gene expression occurs. To do that, I'm going to use three compounds. Rifampicin, also known as rifampin. It's an antibiotic used in spinal meningitis and yeast infections in AIDS patients. Phenobarbital is a sedative, puts folks to sleep, reduces anxiety. St. John's wort is that herbal remedy we've already talked about, and their effect in liver and intestine is to activate the xenobiotic response. Now shown here is actually the compound, let me get the pointer here, rifampicin, but this compound can be thought of as also the active parts of phenobarbital, St. John's wort, and they all bind, in addition to their therapeutic target, have another target in our liver and intestine. It's a member of the nuclear receptor superfamily called pregnane X receptor. It forms an obligate heterodimer with its partner RXR, and together they regulate phase 1, phase 2, and phase 3 gene expression coordinately. So you get upregulation of CYP3A, UGT1A1, OATP2, and MRP2. In other words, you get upregulation of oxidative metabolism, conjugative metabolism, as well as transporter proteins. Phase 3 proteins, they're not enzymes, they're transmembrane transporter proteins. And there's myriad of them all over the body. And they play a huge role in kidney, liver, intestine, and moving organic ions in and out of cell membranes. And I'm going to describe to you in the following slides clinical relevance of phase 2, specifically UGT1A1 and phase 3, OATP2 and MRP2. Turns out there are genetic mutations that have huge effect in the gastrointestinal and GIGU systems. So those slides are forthcoming. So now I'd like to review membrane transporters in drug development and drug discovery. This is all lifted from an article in Nature, specifically Nature Reviews Drug Discovery, issue 9. So you have a picture of an intestinal epithelial cell, also called an enterocyte, and all the transporters that are expressed. This is where your food is or your feces. There are specific transporters that move organic ions in, and other transporters that move them back out. This PGP is an important one. It's a therapeutic barrier to getting drugs on board orally. And then there's, on the blood side, proteins that move organic ions into the blood, and those that move it back and forth. So in hepatocytes, there's myriad transporters on the blood side, and then different transporters on the bile side, and others that move conjugated organic ions back into the blood. Well, they'll be excreted by the kidney. Specifically, the kidney proximal tubules have a myriad of drug transporter proteins, both on the blood side as well as on the urine side. Moreover, the blood-brain barrier is comprised of these drug transporters. And in this lecture, we're going to talk about OATPs as well as MRP2s. Okay? Okay, a brief review of what we've talked about so far. Phase 1 and Phase 2 drug biotransformation. By the way, these pathways also regulate endobiotic, steroid, eicosanoid bile acid metabolism as well. So every time I say biotransformation, that applies to xenobiotics as well as endobiotics. These enzymes and transporters all have broad substrate selectivity. They're very promiscuous in nature, in other words. So phase 1 biotransformation reactions introduce a functional group. Some of them are listed here. There's a small increase in hydrophilicity as a result of these additions. Interestingly, these sites of addition become reactive sites for phase 2 reactions, and they produce a large increase in hydrophilicity. So you go from a relatively fat-soluble to a water-soluble compound, organic ion that can be excreted more readily. Here's a list of reactions: hydrolysis, reduction, oxidation, and then phase 2 conjugation reactions. Phase 1 reactions are listed here, and they are myriad, and here's their localization within cells. Phase 2 reactions are listed here. You can add a sugar, sulfate, glutathione, amino acid, acylation, methylation, and their localizations as well. So without further ado, let's do the genetics of GI disorders. So here is learning objective 1. Compare and contrast the genetic disorders related to heme metabolism, including Criggler-Najjar Syndrome and Gilbert's disease, Dubin-Johnson Syndrome, and Rotor Syndrome. Criggler-Najjar Syndrome. It's a rare autosomal recessive inherited disorder. Affects the metabolism of bilirubin. It causes non-hemolytic jaundice. Higher than normal levels of unconjugated bilirubin is how it presents. It causes severe brain damage in infants. And here's a typical vignette. An infant is brought to the pediatrician by his parents because they're concerned about the yellow color of his skin. Infant is something you should key in on, as well as the yellow color. And general behavior changes is also an important clinical presentation of these infants. Tired, weak, arms just flopping, so that's starting to suggest neural disorders. And the parents are known to be first cousins. Okay, that's important because it's an autosomal recessive. Alrighty then. Now that I've showed you the typical vignette, let's get a little bit deeper into Criggler-Najjar. Your patients are going to present with a hereditary form of unconjugated hyperbilirubinemia. What does that mean? Well, high levels of bilirubin in the blood that are not conjugated with glucose. Moreover, there's absent or extremely low levels of hepatic bilirubin glucose, or glucuronidated bilirubin, or they call them bilirubin glucuronides. You'll see all of those terms. They're synonymous. So in type 1, your patients will present with severe jaundice and kernicterus. Kernicterus is another word, it's a fancy word, $10 word for bilirubin-induced brain dysfunction. So what happens is the bilirubin backs up in the blood, gets it to a concentration that it's able to permeate the blood-brain barrier, and that has severe developmental effects and neuronal manifestations. Type 2 is less severe, and you'll see why in a second. But both present very early in life and result in brain damage in infancy. So it's fairly serious. Okay, moving on. We can see here that Criggler-Najjar and UGT1 have an intimate relationship. In type 1, there's a mutation in UGT1A1 gene that renders the enzyme activity totally absent, or it's not expressed. So mutations in the open reading frame that render the enzyme activity dead. This is a dead enzyme that's expressed, or if it's not expressed at all, that's called type 1 Criggler-Najjar. Type 2, aka Rotor Syndrome, is a mutation in the UGT1A1 coding region which renders the enzyme defective and less active than normal. Get that laser pointer. So overall, what we're talking about is the breakdown products of heme go to biliverdin and then to bilirubin through the actions of HO, or heme oxygenase. And that uses reducing equivalents from NADPH, which comes, as we know, from the pentose phosphate pathway. Biliverdin to bilirubin is catalyzed by biliverdin reductase, again consuming NADPH, to produce bilirubin, which is then acted upon UDP glucuronosyl transferase isoform 1A1 to produce a glucuronide bilirubin conjugate. So you'll hear bilirubin conjugate or conjugated bilirubin or bilirubin glucuronides. In other words, it's bilirubin with the glucose stuck on it. And because glucose is water soluble, it gets excreted. So the focus of Criggler-Najjar type 1 and 2, aka Rotor Syndrome, is UGT1A1. So it turns out all of the enzymes in the biotransformation pathways we're talking about have a broad substrate selectivity, and they're able to metabolize other compounds as well. And UGT1A1 is no different. It metabolizes anti-cancer drugs. One of the more nasty anti-cancer drugs is called SN38. It's nasty because it's incredibly toxic and brutal on patients. It's actually an active form of the drug that's converted by a phase 2 reaction in intestinal carboxylesterase. Turns out enterocytes have tons and tons of this carboxylesterase. So medicinal chemists very smartly put an ester group on irinotecan, and it's administered as a prodrug that's relatively non-toxic until it hits the intestine. Then it's converted to SN38 by carboxylesterase at that location, kind of selectively. So UGT1A1 adds a glucose group to that, and then that glucuronide SN38 molecule is excreted in bile and feces. Here's the glucose. What that is derived from is UDP glucuronic acid. This is just glucose conjugated to a high energy molecule. These two phosphates endow a degree of energy and render glucose kind of a leaving group. And so what happens is you get glucose, and then in the end you get UDP as a side product. And what I'd like to say here is that humans have many UGT enzymes. There's two subfamilies, UGT1 and UGT2, and in each subfamily there are numerous, looks like 9 and 10 respectively in the UGT1 and UGT2 subfamily respectively. Okay, so that's fairly interesting. Again, the focus of our talk today is just UGT1A1. So you might be wondering, what do these other guys do? Well, they do myriad other. They stick glucose on other things other than bilirubin or biliverdin or anything. They stick glucose moieties on other drugs, other endobiotics, other xenobiotics. By the way, the word xenobiotics just means foreign compounds, stuff that you eat, drugs that you take, stuff that you breathe, stuff in food, xenobiotics. Pharmacology, pharmacotherapy, those are xenobiotics. How do your patients present in Criggler-Najjar? Well, neonatal jaundice, sepsis, hypotonia kernicterus, which can manifest in deafness, poor mental progression, poor mental development. They're jaundiced, and they have oculomotor palsy. We're going to talk about prognosis prevention and complications associated with Criggler-Najjar. Among them is kernicterus, and that's a result of bilirubin deposition in the brain. It results in poor developmental function and poor mental function. If it's really bad, patients are going to die within a few years. Let's focus now on treatment of Criggler-Najjar. Plasmapheresis, the bilirubin lights phototherapy, phenobarbital, a UGT1A1 inducer through the mechanism I've already described, only for type 2, and this makes sense if you think about it, because type 2 expresses a mildly dysfunctional form of UGT1A1, whereas type 1, the enzyme is dead or not expressed at all, so phenobarbital would have no effect. Liver transplant is another treatment. Let's talk about Gilbert syndrome right now. This is what it looks like. This is how it manifests. You can see the yellowness in this patient's eyes in particular, a little bit of yellowing through the eyes here. A typical vignette. A 24-year-old third-year medical student is 2 weeks into her first surgery rotation when her senior resident tells her that her eyes look a little yellow. That probably stressed her out a little bit. She experienced her first needle stick injury in the operating just 1 week earlier, and she begins to worry about hepatitis because, hepatitis is a virus that infects your liver and shuts down its function, and that would lead to jaundice. So other than rarely having the time to eat at work, she has no other complaints or symptoms. Okay. This student doctor is suffering from Gilbert syndrome. Gilbert syndrome is a hereditary condition due to unconjugated hyperbilirubinemia. There's a defect in the gene promoter for UGT1A1, but the UGT1A1 that is expressed is functional. So what you see is a mild decrease in UDP glucuronosyl transferase activity due to the lower expression level of the wild type enzyme. This produces a mild decrease in bilirubin uptake. This syndrome is inherited either as autosomal dominant or recessive. It's very common in the human population. So how do these patients present differently from Criggler-Najjar? So they're largely asymptomatic. She's 24. She's not an infant. Okay? So she made it through, which suggests that it's Gilbert syndrome right away. The age of the patient in the vignette is a big hint. Occasional recurrent but mild jaundice. You notice her skin wasn't yellow. There wasn't any mental disorders. It's associated with fasting. Interestingly, they don't really know how fasting increases bilirubin in the serum or hyperbilirubinemia, but they think that increased hepatic uptake of non-esterified fatty acids that occurs in fasting, and you learned about that in SFM, that increased uptake interferes with the clearance of bilirubin and thus contributes to the unconjugated hyperbilirubinemia of fasting. In other words, these fatty acids are taken into the liver by the same transporter that brings bilirubin in as well. Stress, medical school, infection can also produce symptoms, and drinking ethanol can produce symptoms. So again, how do you distinguish between the two? Well, the age was a big thing, but unconjugated hyperbilirubin without evidence of hepatitis or hemolysis, or even neuromuscular disorder or neural dysfunction. So there's something called a fasting test, and it turns out unconjugated bilirubin normally rises during fasting, but it rises way more when there's Gilbert's present because of the defect in UGT1A1. Folks without Gilbert's test, well, it'll rise, but But if they had Gilbert's, it would rise a lot more. So that's another way to distinguish. There's also a rifampicin test. Rifampicin, those are synonymous. It can be used to diagnose Gilbert's. I'll let you read through this. Just know that there's a test, a fasting test and a rifampicin test associated with Gilbert syndrome. Okay? But without evidence of hepatitis or hemolysis is the big point of this slide. Okay, there's no treatment needed. There's no clinical consequences, and if it makes sense by now, it really should. Folks with Gilbert syndrome need to avoid certain medications that are heavily metabolized by UGT101. For example, SN38 or the active form of irinotecan, right? And to harken back to what I'm talking about, if this enzyme is defective, this is not going to happen very well. It won't be excreted as well in patients with Gilbert's, and so you would like to avoid this because it's exquisitely toxic. So it would be kind of stuck in this form in patients with Gilbert's, or it would be less able to get out of the body. And by the way, you want poison to leave your body. Okay, so that's Criggler-Najjar, Gilbert syndrome. Now let's move on to two other syndromes we're going to talk about in this lecture, including Dubin-Johnson Syndrome and Rotor Syndrome. Okay, here's a typical vignette. 22-year-old motorcycle accident victim brought to the ED with severe head injuries, stabilized and brought to surgery where he's deemed to be brain dead. Physicians like to call folks who ride motorcycles, or they call motorcycles, donor mobiles. Okay, so the organ transplant team is contacted and determined that he's an eligible kidney donor. However, he's not eligible for liver, they determined. So they opened him up and they saw his liver is black. And this is Dubin-Johnson Syndrome. It's mutations in MRP2. So these folks obviously live, but mutations in MRP2, which is a ABC transporter that lives on the canalicular side of the hepatocyte to transport stuff into the bile. And this will make sense in the following slides. Whereas Rotor syndrome is mutations in OATP 1B1 and 1B3. These are uptake transporters. So these guys transport stuff from the blood into the hepatocyte. This MRP2 transports stuff from the hepatocyte into the bile. And you can see that here. Here's the hepatocyte, and here's OATP. Here's the blood, and here's the bile. So the OATPs, you can see by this arrow, they're uptake transporters, whereas MRP2 transports stuff from the intracellular aspect of the hepatocyte into bile. So you can see that if MRP2 is mutant and dysfunctional or absent, MRP2 substrates, i.e. conjugated bilirubin or other stuff, would be unable to get into bile because these transporters all have their own substrate specificity. Bile salt excretory protein, for example, transports bile salts. PGP transports certain drugs into the bile. MATE transports specific bile acids into bile. BCRP transports other stuff. You have cousins to MRP2 called MRP3, 4, 6, and they transport stuff, conjugated organic ions from the intracellular aspect of the hepatocyte back into the blood, where they can then travel to the kidney and be excreted that way. So the liver and kidney talk to each other quite a bit. If it can't get into bile and it has to get out somewhere, it'll get kicked back out into the blood, travel to the kidney, where different transporters from the blood will get it into the kidney proximal tubules and get it out into the urine. Okay? Awesome. So as an introduction, instead of unconjugated hyperbilirubinemia in Dubin-Johnson and Rotor's, you get conjugated hyperbilirubinemia. due to a decreased hepatic excretion of conjugated bilirubin. So it backs up into the hepatocyte and eventually spills back into the blood because it can't get out. But yet you have UGT1A1, which can stick a sugar on bilirubin, which is the major way it's metabolized. And so in Dubin-Johnson and Rotors, because UGT1A1 is functional, you get increases in conjugated hyperbilirubinemia. Hopefully that makes sense to you. So there's two types. One is Dubin-Johnson and Rotors. The way you distinguish them in Dubin-Johnson, you get this black liver due to impaired excretion of epinephrine metabolites. It's benign and it's autosomal recessive. So you got to get both alleles, one from your mother, one from your father, to have Dubin-Johnson syndrome. In other words, one allele of functional MRP2 is enough to overcome. It's enough to function well enough to have no side effect of this black liver thing. Whereas Rotor syndrome is much milder than Dubin-Johnson, and it does not cause black liver. Okay? So if you see a black liver, think Dubin-Johnson. And it's due to the accumulation or the inability to excrete epinephrine because of non-functional MRP2 transport activity. Here's a picture that a pathologist might show you, and here's a more gross picture of a black liver. Whoa, you can't put that in a recipient. So this donor, the liver was rejected. And this is again what a slide a pathologist might show you looks like. That's Dubin-Johnson. A pigmented substance. In other words, metabolites of epinephrine. I believe they're called metanephrine. Okay, a little bit deeper dive on Rotor syndrome. Similar to Dubin-Johnson, but the liver is not black. No specific therapy. Patients with Rotor syndrome have mutations in both the OATP1B1 and 1B3 uptake transporter genes. This results in impaired secretion and or impaired storage of bilirubin in the liver. Isn't quite clear. It's characterized by predominantly conjugated hyperbilirubinemia in these patients, and they're generally asymptomatic. Jaundice can be an incidental finding. Typically more than 50% of the serum bilirubin in these patients is conjugated, and bilirubinuria is typically present. Most patients are asymptomatic with Rotor syndrome, but they may become jaundiced or icteric during fatigue, pregnancy, or with oral contraceptives. And this is likely due to a reduction in hepatic excretory function, presumably due to competition for hepatic excretion between oral contraceptives and conjugated bilirubin. So some of the labs and patient evaluation differentials may include elevated direct conjugated hyperbilirubinemia, increased total bilirubin, specifically in Dubin-Johnson syndrome, copropofferin 3:1 ratios ranging from 1:3 to 1:4. By the way, this is opposite of normal. Total urine copropofferin levels are elevated in Rotor syndrome. However, they're normal in Dubin-Johnson syndrome, so that's another differentiating factor. From a gross pathology standpoint, in Dubin-Johnson syndrome, there's dark black liver, and no treatment is actually needed in these patients. Okay, here's a practice question for you. So impaired UDP glucuronidyltransferase, aka UGT1A1, is observed in all of the following except what do you think the answer is? Well, breast milk jaundice is rare, probably from inhibition of UGT activity. It's not too clear, but UGT is fingered in this breast milk jaundice pathology. So it's not A. And B, jaundice of the newborn is underdeveloped UGT activity. I don't know if I told you this, but UGT activity is very low until an infant comes to term, and it turns out as they're being born, UGT activity is stimulated and it increases immediately after birth. So UGT is all over physiological jaundice of the newborn. Criggler-Najjar we just went through, and that's mutant UGT. So UGT is involved in A, B, and C. So the answer is D, because it's a mutation in MRP2, has nothing to do with UGT1A1. MRP2 is that transporter that transports conjugated bilirubin from the liver, from the hepatocyte, into bile. Okay, that's learning objective 1. Now let's move on to learning objective 2, which is related to hemochromatosis and Wilson's disease, related to iron and copper metabolism. We're going to focus on Wilson's disease. But go ahead and read this. It's good board prep material. There's some good explanation of hemochromatosis and Wilson's disease. I'm going to cover heavily Wilson's disease for obvious reasons. So here's a typical Wilson's disease vignette. 33-year-old female, referred to a neurologist, unsteady gait, forgetfulness, recent episodes of Tourette-like spells, flinging one arm out, unprovoked, neurological dysfunction. Irises appear multicolored with concentric rings around the periphery. Order several labs and radiologic studies. Advisor to avoid eating chocolate and shellfish. These are foods that are very high in copper. Moreover, drinking water should be analyzed because it could contain too much copper. This is a picture of those concentric rings. Pretty marked. You don't see this in other diseases, so this is fairly indicative. If you're on a diagnosis of exclusion and you see this, you just leap to Wilson's disease. So by way of introduction, in Wilson's disease, patients accumulate copper in many tissues, including liver, brain, cornea, joints, especially in brain, thus the neurological manifestations. This is also known as hepatolenticular degeneration. But the mutation is in a transporter protein that uses ATP to transport copper from one side of the membrane to the other. The transporter is called ATP7B. The net result is a lack of an ability to excrete copper into bile. Thus, there's also a failure of copper to enter circulation bound to cellular plasmin. By way of comparison, just like transferrin is for iron, cellular plasmin is for copper. So typically, like iron, free copper is bad. So copper bound to cellular plasmin normally represents the largest fraction of copper in the body. But in these patients, it's free. And this free copper generates free radicals that damage tissues. And it's an autosomal recessive inheritance. So here's a pictorial representation of Wilson's disease. What you'll notice is copper from our diet is in the lumen of the intestine, is transported by CTR1 into the enterocyte, where it forms a complex with a protein called ATOX1, which then complexes with ATP7A, eventually resulting in the release of copper into the plasma, where it's bound to cellular plasmin, and it's carried to the hepatocyte, where ATOX1 again carries it to a transporter related to ATP7A, the mutation in Wilson's disease in ATP7B. So without ATP7B, what happens is free copper builds up in the plasma, and that's bad. And here's a picture, ribbon diagram. I just show you this because it's beautiful. This thing binds ATP, takes a molecule of copper from the outside, and shoves it to the other side of the membrane. And biochemistry is super cool, people. Here's another picture. There's phosphorylation domains, copper binding domains, ATP binding domains. It's an 8 transmembrane transporter that moves copper from one to the cytosol into the lumen, or from the hepatocyte into the bile. Okay, the big deal with this is CNS presentation. Deterioration in school performance, behavioral changes, all kinds of CNS manifestations. You'll also get manifestations in liver and kidney and in the eye. You can get like rickets and heart dysfunction. So it's a very serious disease. Okay, the presentation: Parkinson's-like symptoms, this flailing movements, dementia. You'll see cirrhosis of the liver and these so-called Kaiser-Fleischer rings. And these type of rings, this manifestation in the iris of the eyes, is rarely seen in any other condition. But for example, primary biliary cirrhosis, if you have a really sick liver, you might start to see that kind of a thing, in addition to jaundice. Further evaluation of a Wilson's disease patient might include decreased total serum copper, and that's due to decreased ceruloplasmin in these patients, an increase in serum non-bound copper, an increase in urine and serum-free copper, as well as hemolytic anemia. If you go that far, you can do a liver biopsy. What you'll see is increased hepatic copper in these patients. So let's talk now about how you treat patients with Wilson's disease. There's both medical treatments as well as surgical treatments. Chelation therapy is a frontline treatment, and there are several choices. 3 are listed here: ammonium tetramethylmolybdate, penicillamine, and trientine. All are copper chelating agents. Moreover, administration of high levels of zinc, and that's because zinc competes with copper for absorption in the gut via the same transporter. So if you flood that transporter with zinc, it won't allow copper to be absorbed. Surgical treatment, if it gets to that point, you should consider a liver transplantation as your patient's clinical condition deteriorates. So now let's talk about some of the complications and the general prognosis for patients with Wilson's disease. It turns out Wilson's disease itself is a risk factor for several other liver diseases, including hepatitis, cirrhosis, and even hepatocellular carcinoma. Patients with Wilson's disease are also at risk for developing Fanconi's disease of the renal proximal tubules. So here are your learning objectives for Learning Objective 3. You need to be able to compare and contrast the genetic disorders related to carbohydrate metabolism, including galactosemia, hereditary fructose intolerance. Readings from Panini are listed here, and there's a particular emphasis on the boards on galactosemia, fructose kinase deficiency, and aldolase B deficiency. Moreover, in Learning Objective 3, you should be able to compare and contrast the genetic disorders related to carbohydrate metabolism, including phosphoenolpyruvate carboxykinase deficiency and von Gehrig's disease. Additional readings from Panini are listed here, and it turns out much of this material was covered in Dr. Zaidi's carbohydrate metabolism lecture, but all of these are good for your long-term board prep future, not so good for your near-term future. So I'd like to thank you very much. The following use, they include practice questions that have the answers and rationales already associated with them. Listen, it's my honor to be one of the first lecturers in this brave new world that we're all facing together. Stay strong, and let's move forward in a positive direction. If I'm a little awkward at this, we'll get better as time moves forward, and I anticipate I'll get a lot better fairly quickly. So thank you so much. Again, it's been my honor to lecture to you in this regard. Take care, people.